So we are all live now. We can start.
Good morning, friends. It's our pleasure to welcome all of you to this Facebook Live session by the Institute of Chest Surgery at Medanta on a very vital topic of lung cancer and improvement of lung health, and to popularize the hashtag I care for lungs. But before we move, let me have the pleasure of introducing myself, and my colleagues. So I'm Dr. Professor Ashish Kumar. I'm Chairman, Institute of Chest Surgery at Medanta, the Medicity, and also the founder trustee of Lung Care Foundation. And it's my pleasure to introduce my colleagues in the department. So uh, Dr. Bilal bin Asaf. Dr. Bilal, if you could raise your hands.
Yes.
Dr. Bilal bin Asaf is a thoracic surgeon who is the associate director at Institute of Chest Surgery and also a founder trustee of Lung Care Foundation. Next, Dr. Harsh Bardhan Puri. He's a consultant at Institute of Chest Surgery and also a very active member of Lung Care Foundation. Next, Dr. Sukhram Bishnoi. Dr. Sukhram, if you could kindly raise your hands. Dr. Sukhram is an associate consultant at Institute of Chest Surgery and also a very vibrant member of Lung Care Foundation. And last but not the least, Dr. Mohan Venkatesh Pule, who is also an associate consultant at Institute of Chest Surgery and a very active member of Lung Care Foundation. So myself, along with Dr. Bilal, Dr. Harsh, Dr. Sukhram, and Dr. Mohan, we are going to be with you, ladies and gentlemen, for the next 50-55 minutes to discuss with you the important issue of lung cancer awareness, how the lung health is getting destroyed, and how we can care for our lungs. First and foremost, why are we discussing this topic? Friends, cancer, as you all know, is an uncontrolled, uninhibited growth of cells in the body. Our cells grow in whole body, becomes uncontrolled, it's called cancer. And when that cancer occurs in the lung, it's called lung cancer. In the pre-industrialized world, lung cancer was unknown. But as the industrialization started with the discovery of steam engine and also concomitantly as the use of tobacco, the cigarette and other forms of tobacco smoking started, the lung cancer appeared on the medical scene, and sadly over the last 50 years its incidence has been increasing steadily in the western world and thereafter in our country also, due to various measures. In countries like US, at least in the males, the incidence of lung cancer seems to be hitting a plateau. But unfortunately, and very unfortunately, in our country, last 10 years have seen a very rapid rise in the incidence of lung cancer, to the extent that in many lung cancer registries in our country, the lung cancer is the number one lung cancer in males and is also very rapidly rising in ladies. Along with that, there are many other demographic changes that me and my other four colleagues have noticed in the last 10 years of a journey together on this topic, which we'll be sharing with you over the next 1 hour. November month happens to be the Lung Cancer Awareness Month, and this is done mainly to raise awareness about this important topic of lung cancer and to make people aware as to what is happening and take corrective steps to reduce. Let me share with you, this is one of those cancers which is completely preventable if the causes which cause this can be avoided. So before we move into the various diagnosis and other areas, let's first discuss some of the important demographic changes that we have noticed in the lung cancer during the last 30 years of journey. Maybe Dr. Bilal, would you like to share with our viewers what major changes we have noticed as a group in the lung cancer, smoker versus non-smokers, the age-related change, the sex-related change, the kind of changes we see in the color of the lungs that we want to share. Dr. Bilal, please.
It's a very important question, and one that we need to realize that the demography that we used to see about a decade back, as far as lung cancer is concerned, has changed significantly. So, if I take the earlier part of our career when we started treating such patients, most of the patients would present in the sixth or seventh decade of life, and they would be chronic smokers, elderly age group patients. However, in the past couple of years, we have noticed a dramatic change. We are seeing more and more non-smokers who have never smoked presenting with lung cancer, and also the disease is now occurring in much younger age groups also. And surprisingly, we have seen the youngest that we have seen is in a 28-year-old female. So earlier, the disease was very limited to males mainly, so it was more common in males. But nowadays, we are seeing a lot of females also presenting with lung cancer. And as far as your question about the condition of the lung is concerned, sir, as you know, we have been talking about this for so long. Earlier, we used to see much. The lung is quite a pink and a spongy organ, and when we used to go inside doing the surgeries, we used to find pink lungs. But nowadays, majority of the lungs that we found have a lot of black mottling over it, which could be the effect of pollution. So the demography has changed significantly. Earlier, it used to be elderly males. Now it is common in younger age group, and a lot of non-smokers are also presenting with lung cancer, which is a very worrying development.
Very, very well stated, Dr. Bilal. These are very, very strong points which need to go across to 1,300 million people of our country. And just for the sake of hammering these points again, I'm going to repeat these, although Dr. Bilal has very elegantly described them. So, ladies and gentlemen, Dr. Bilal stated 5 major changes. Number 1, earlier, when we used to operate, and all 5 of us are chest surgeons who operate about 3-4 cases every day, and we see people's lungs from inside, which none of you is able to see. We can't see our lungs, but we can see our patient's lungs. So what we see earlier, when we used to operate, we would see mostly pink lungs because that's how we are born with, except in smokers. Sadly, these days, when we operate, we rarely see pink lungs, even in so-called non-smokers. Even in teenagers, we find black deposits, which is an evidence of the amount of toxins that each one of inhales from the very first breath of life. So that's the first major change. Ladies and gentlemen, all of us are having black deposits on our lungs. Be clear about that. Number 2, earlier we used to see 90% of the patients as smokers. Currently, our data shows, and we see a huge number of lung cancers in our clinic every day. Current data shows about 50-50, which means 50% of the patients are so-called non-smokers. Third, mostly patients used to be in 50s and 60s. Now they are in 40s, and about 10% of the patients are in 30s. In fact, the youngest patient this group has seen and managed was a 28-year-old non-smoker girl from a non-smoking family. Major change, ladies and gentlemen. Fourth change, earlier majority of our patients were men, and now 40% of our patients are women who are non-smokers from non-smoking families. And number 5, this incidence was less overall. If we look at all the cancers, lung cancer used to form a small percentage of the overall cancer burden of any cancer center, and today lung cancer in men and also rising in women is forming bigger and bigger segment of the overall cancer bundle. 5 major changes, ladies and gentlemen, and that's why this group at Institute of Chest Surgery at Medanta has taken it upon itself to reach out to people, all of you, and we request all of you to share this information with all your friends and colleagues, because we want this information to reach people, because it is only through the dissemination of information that we will be able to control this couch. Okay, moving on. What are the symptoms that people should be very concerned about? Because unless we tell people, how should they suspect, they would not know. So Dr. Harsh, I would come to you. If you could just describe, does every lung cancer have symptoms? One. And two, if not, how do people get diagnosed? How do they present? And what are the symptoms that you should be concerned about? Dr. Harsh.
So very pertinent question. Basically, what we see in our OPDs also, the lung cancer is mostly divided between two categories. One category of patients are completely asymptomatic. They don't have any symptom of lung cancer. And as we have seen in COVID also, that few patients who got their HRCT done because of the COVID problems were diagnosed to have some spot in the lung or some tumor in the lung, which was further diagnosed on evaluation as lung cancer. So it in one subset of the patient, it can be completely asymptomatic. So here comes the role of screening, which will be discussed in further course of the program, how lung screening is helpful in diagnosing lung cancer in high risk patients. The other subset of the patient is symptomatic patients. Now the symptoms can vary from very mild to very severe. What mild symptoms are: a chronic cough which is not going, hemoptysis, which is balgam mein khoon aana, and maybe some kind of chest pain and something. And further, if the symptoms are when the gravity of situation increases, the patient presents with breathlessness, increasing breathlessness on exertion, like walking, like stair climbing and all those. And in the later stages, when the lung cancer becomes disseminated, the patient can present as as bone pains, as seizures, as liver failure. So this is commonly in stage 4 cancer. So my request to viewers is, if you have a chronic cough, if you have slight sputum which is bloody, you should immediately go to your physician or a surgeon or a thoracic surgeon or a chest specialist and get yourself evaluated, because of the increasing pollution. As you have already told, that the age group of lung cancer has shifted from 60s to 30s now. So everybody falls into that circle of getting the lung cancer because of the increasing pollution, increasing smoking and all that. So mostly it can be divided into asymptomatic and symptomatic.
Very well said, Dr. Harsh. I would re-summarize. So there could be two groups. One, where there are no symptoms. You just have a cancer developing in your body and you just get some tests done and you get detected. As fortunately, Dr. Harsh, it has happened with us so many times in the recent COVID pandemic that people had their HRCT done for the purpose of COVID and some mass was detected. So that's a called coincidental discovery. But otherwise, when there are symptoms, as he said, any cough which refuses to go away beyond a few weeks, especially if it's associated with blood in the sputum, these two symptoms in anybody above the age of 30 years. Earlier we used to say 50 years, but today, considering the kind of cases we have seen, I would say anyone above 30 years, if you are having these symptoms and you have a patch in chest x-ray, do not suppose it to be anything else unless you exclude it. Dr. Sukram, in our country, tuberculosis is also very common, and as we are aware, tuberculosis also presents with cough and blood in the sputum with a patch on the chest x-ray. And same thing happens in these patients of lung cancer also. So is this a real problem in our country? Do you in your practice see that sometimes the cases get misdiagnosed? Does this happen? Should people be aware? Any message you would like to give to the country? Dr. Sukram. Unmute
Yeah.
yourself, Dr. Sukram.
Yes, sir. Am I
Yeah.
audible?
Yes,
Ji.
please go ahead.
Sir, there are cases which are mostly misdiagnosed because of the tuberculosis. Initially, when patient has these symptoms, because there are no lung cancer specific symptoms like cough, hemoptysis, or breathlessness. All these symptoms are commonly occurred in TB as well as in the lung cancer. So they initially people don't go for tissue diagnosis or further investigation, and they get treated with on X-ray they seen the patches and initially started with the lung cancer, and if they don't respond, then the further investigation are being done. So people should be aware of that. If they don't have tissue diagnosis or the further investigation, then they should every case of the hemoptysis or breathlessness or cough should not be treated as a tuberculosis. It may be the lung cancer also.
Yes, very well stated. I would rephrase it. So, tuberculosis is much more common in our country. It also presents as cough and sometimes blood in the sputum, which may occur at any age group, from a few-year-old child to an elderly person. And lung cancer, usually I would say in 30 plus, of course in 40 plus, also presents with cough and blood in the sputum. So the message is, anyone above 30 today, if you see cough with blood in sputum and there is a patch on chest x-ray, please do not suppose it to be tuberculosis and start the patient on anti-tuberculosis treatment without a confirmation of the diagnosis of tuberculosis, because you never know, hidden in that group of tuberculosis patients may be an isolated patient of lung cancer who, if put on anti-tuberculosis treatment for many months, will lose precious many months and will have advancement of the tumor. Early stage tumor may go into advanced stage tumor. So the message is very clear. Please have a confirmation of the diagnosis. Now, Dr. Mohan, we are talking of confirmation of diagnosis in these patients. So you have a, say, 35-year-old person who comes to you with cough and blood in sputum and a patch on chest x-ray. It could be tuberculosis, it could be lung cancer. How, of course, it's a medical area, but we may give a message to people, some basic simple tests which they can ask the doctors to get done if the doctor does not advise, which can help them differentiate between tuberculosis and lung cancer. Dr. Mohan.
It's a very pertinent question, sir. The way the lung cancer is diagnosed, when a patient had the symptoms and the patches being shown in the chest X-ray, the patient should undergo or should ask the physician to undergo to get the CECT chest, a chest CT scan of the chest, where because it's a 3D reconstruction of the chest, you can exactly see the characteristics of the lesion, which area in the lung it is present, what is the size of the lesion, what are the characteristics of the lesion, and other information that we can definitely get better idea regarding the lesions. And for the confirmation of this lesion, whether it is a lung cancer or it's a tuberculosis, many of the situations we need a true cut biopsy where a needle is inserted into the lesion and the sample is sent for microscopic examination, where we can differentiate between a lung cancer and a tuberculosis. Sometimes the patient can have a bronchoscopy where a durbin is inserted into the airway and where we can take the samples, and in that situation also under the microscope we can differentiate between a lung cancer and a tuberculosis. And once the diagnosis of lung cancer is complete, is done, and then to stage the disease, we advise the patients to get a PET scan. It is type of a PET scan. It can be done.
Hold on. We'll come to that. I think, yeah, Dr. Mohan, what you have said is you've asked for a CT scan to be done. You've asked for a biopsy confirmation to be done by either CT scan guided biopsy or a bronchoscopic biopsy. Dr. Mohan, what you have said is absolutely correct, pertinent. However, we are a huge country, 1,300 million people spread across the length and breadth, including rural areas. What I would add is that suppose you are in a remote area, where all these facilities may not yet be available, but there is one test which is sputum examination for tuberculosis bacteria, which is available, I think, across the country. Most of the PHC sub-centers, tuberculosis centers are now having this facility. So I think if you just go for this test and you find a positive tuberculosis bacteria in the sputum examination, you have a very strong suspicion basis for starting off of anti-tubercular treatment. Not to say that every case of tuberculosis will be positive, but at least it's positive, then you know you are on the right track. And if it's negative, then you should always be little worried that, okay, maybe I need to confirm this diagnosis. Message is very clear that hidden amongst a large number of these cases may be isolated cases of lung cancer. And if we have to pick up these cancer, the doctors, not the public, the doctors, medical personnel across the country have to know that lung cancer is now occurring with increasing frequency. It is occurring in younger and younger people. It is occurring in non-smokers. It is occurring in women also, and it is increasing in frequency, and therefore high index of suspicion. Not giving ATT and forgetting for 6 months should be the approach which medical personnel should be following. Right. Very well stated, Dr. Mohan. I come back to Dr. Bilal. Dr. Bilal, we have talked about symptoms. We have talked about doing CT scan for the characterization of the lesion. We have talked that for confirmation of the diagnosis, he needs to do a biopsy, which could be either a CT guided biopsy from outside or a bronchoscopic, that is Durbin guided biopsy from inside, and you get all that. So this will all help us confirm the diagnosis. Now, I want to ask you a very practical question, which all of us face in the OPD, and I want you to give a very categorical, clear message. A lot of people ask us, doctor, don't you think doing a biopsy is going to spread the cancer very fast? What's your take, Dr. Bilal, on this?
Thank you, sir, for the question. And I think that is one of the most common questions that we come across when a patient comes to us. They have a lesion in their lung, which was detected by a variety of methods. And the first thing that we advise is that such lesions should be biopsied, because biopsy gives a confirmatory diagnosis whether it is cancer or not, and helps us in planning the treatment. The next common question that comes is when there is a belief in people that if you touch that biopsy by any means, or touch that lesion by biopsy, it tends to grow in a faster way. Now, this belief came from the previous problems that before the era of true-cut biopsy was there. So earlier, such biopsies were done by open methods. And what people used to do is they used to make the cut in the chest and take the biopsy from that. And that would lead to increase in the spread of the disease in terms of because of the procedure itself. But nowadays, the mechanism of biopsy is so advanced. We use a very fine bore needle, which is then injected into the lesion on CT imaging, and a very fine core of tissue is taken out of it. So in that case, there is no additional risk of the spread or sudden increase in the size of the tumor. So this belief is now baseless, and in fact, it does more harm than good to people who wait for the disease to grow to such extent and then only go for biopsies. So biopsies should be done at a very early stage, and it does not lead to the spread of the tumor, or it does not lead to an increase in the rate at which the tumor grows. This belief we need to shatter, and with such programs and raise awareness regarding this is very important to make a very categorical statement that biopsy does not lead to increase in the spread of the tumor or the rate of the spread of the tumor.
Okay, very well stated, Dr. Bilal. The biopsy of a lung cancer mass does not lead to spread of the tumor. I want all the listeners to please be clear, and I request all of you to please spread this message across your circles, across the globe, that biopsy does not lead to spread of the cancer. Dr. Bilal, I have another question. A lot of people ask this, doctor, you've done CT scan, you've done PET scan, you say it is lung cancer. Why do you want to do a biopsy? Haven't you got the diagnosis on PET scan and CT scan? Why biopsy? What's your answer, Dr. Bilal?
Sir, a biopsy is extremely important for two reasons. Number one, we want whatever we see on the clinical imaging, and this is just a suggestion towards a cancer. In order to confirm the diagnosis, we need to have a biopsy and prove it without doubt that this is cancer. Number one, that is the one reason one should go for biopsy. The second reason that one should go biopsy for is the type of the cancer that is there. So in lung cancer, a lung nodule may be a primary lung cancer, or it could be there from other lung cancers in the body. And also there are different varieties of lung cancer. So in order to have a particular diagnosis and to know which specific type of cancer it is, biopsy is very important. And that is why it helps us in deciding the further course of treatment and specialized and individualized plan of treatment for that particular patient.
So the message is very clear. CT scan tells us about the presence of a tumor, which is likely, I repeat, likely cancer. However, if you take 100 cases which have been diagnosed by a doctor as likely cancer and you do biopsy, probably 99 will turn out to be cancer only, but one odd case may have some unexpected diagnosis. 1. 2. What is the difference between CT and PET? CT scan only sees the chest. So it finds out the presence of a tumor in the chest. It finds out whether it has spread to glands within the chest, is spread to chest areas outside of lung. Is there any water in your chest around the lung? Is there any infiltration by the tumor into the central part of the chest or any of the peripheral? So everything about the tumor within the confines of the chest is told to us by the CT scan of the chest. But CT scan of the chest does not find out anything about beyond the chest. And if you want to know spread of the tumor anywhere beyond the chest, from head to toe, you need to go for PET scan, which scans your whole body from head to toe, and in about 5 to 10% of totally unsuspected cases, it may throw up spread of the tumor from the chest to beyond the chest, making it a stage 4 cancer. And therefore, PET scan is also a very important part of the workup of a lung cancer patient today. But I repeat what Dr. Bilal said, that neither CT scan nor PET scan replaces a biopsy. CT scan will tell us that there is a suspicious tumor. PET scan will tell us where all it has spread in the body. But the final pakka confirmation based on which treatment, surgery or whatever is started only comes from biopsy. So ladies and gentlemen, our message is very clear. If you have a suspicious symptom, please go for CT scan. And thereafter, you need to get the PET scan to know the stage of the tumor. But before your treatment can be started, you need to have a pakka confirmation of the diagnosis, for which biopsy is mandatory. Biopsy does not spread the tumor. No treatment can be started without a biopsy. Dr. Bilal, very well stated, very categorically stated. Thank you so much. Now we move to the treatment part. Dr. Harsh, we have 3 main modalities of treatment of any cancer. 1 is surgery, 2 chemotherapy, or let me call it systemic therapy, which may be chemotherapy which is injected into the veins, or target therapy, which is tablets which are popped into the mouth, or immunotherapy, which is also. So I would club chemotherapy, target therapy, immunotherapy in a one broad category of systemic therapy. So you have surgery, you have systemic therapy, and the third therapy is where we use rays to burn the tumor, which is called radiotherapy. Now, out of these 3 modalities, I want to know from you, because you are an ace lung cancer surgeon, what is the use of surgery in the treatment of lung cancer cases? We'll talk about systemic therapy and radiotherapy later. Dr. Harsh.
So very important question. Basically, thanks for that question. Basically, what happens is the lung cancer is mostly divided into mota 4 stages: stage 1, stage 2, stage 3, stage 4. So what stage 1 is, very early lung cancer, just confined to one of the lobes, smaller size, stage 1. Stage 2 is small, slightly bigger in size, but still confined to the lung. Stage 3 is when it spreads in the glands very adjacent to the lungs, which is called as mediastinal glands. And stage 4 is when it spreads throughout any part of the body other than the lung. So what surgery is useful is if it is a stage 1 cancer, if it is a stage 2 cancer, or a very early stage 3 cancer, the best overall survival after treatment is from surgery. But what happens is that lung cancer should not be treated by one thoracic surgeon or a medical oncologist or a radiation oncologist. It should be a multi-modality treatment where every department, where these 3 or 4 departments come together and plan the treatment of lung cancer in that particular patient. Some patients have got very early, like you previously told, that in COVID, we saw incidental findings of very small lesions in the lungs. We biopsied them and they came out to be lung cancers. So we all of them were subjected to surgery. So what studies have shown is that if a patient falls into category, say, stage 1, stage 2, and if he or she can be operated by surgery, and then if required systemic therapy is started, then the overall survival is much better than stage 3 and stage 4 cancer, where surgery, late stage 3 and stage 4 cancer, where surgery cannot be done. So best modality of management in early lung cancer is surgery. Now, saying that, I also like to say that every lung cancer patient should be discussed in a multimodality treatment, and a particularly very individual plan of management should be formulated for that particular patient. Thank you.
Okay, Dr. Harsh, you've actually raised two very pertinent issues. One, you talked about stage. I think it's a very good point which you raised, which I had missed out, because every patient, when we tell them lung cancer, the next question, Doctor Sahab, hamari stage kya hai?
Stage kya hai?
So let me summarize in a very simple way. There are 4 stages. Stage 1, when the tumor is still confined to within the lung. Tumor is within the lung is stage 1. Stage 2, when the tumor is little bigger or it involves glands which are within the lung substance, you can call it, so bigger tumor in the lung or tumor in the lung and in the gland within the lung, that's stage 2. So this is still confined and totally curable. Stage 3, when the tumor has spread beyond the lung to the glands in the middle of the chest. So you have one lung on right side, one lung on left side, and in the middle is the heart, the windpipe, the food pipe, and you have a chain of glands on either side of these structures which get the lymph from the lungs. So sometimes the tumor comes to these glands in the middle of the chest. So when you have glands in the middle of the chest which have become involved by the tumor, but on the same side of the lung tumor, then we call it stage 3, mota. And when the tumor has gone to opposite sides, so you have a tumor in the right lung, it has spread to glands or lung on the opposite side, or has spread beyond the chest to anywhere in the body from brain to toe, then we call it stage 4 or metastatic cancer. These are broad 1, 2, 3, 4. So stage 1 and 2, as Dr. Harsh very elegantly said, is curable by surgery, and surgery offers the best chance of cure for his patient. Ladies and gentlemen, I want to give a very clear categorical message here. If you have stage 1 and 2 diagnosed tumor, surgery offers the best chance of cure for these patients. When you have tumor involving the middle of the glands, that is we call stage 3, this becomes a group where we use a combination of therapy, as Dr. Harsh said, that not one but a combination. So you give chemotherapy, you make the tumor smaller, and then we operate. But in these cases also, surgery offers a good chance of cure to the patient. But when you have tumor which has spread beyond the lungs into the opposite side, or has formed water around the lungs, or has gone to other parts of the body, what we call stage 4 cancer, then surgery has no role. Those patients then need to be treated by other modes of therapy. Thank you, Dr. Harsh. Very, very elegantly stated by you. So it is the stage. So, Dr. Sukram, now having said that stage 1 and stage 2 is curable by surgery, or offers the best chance of cure, and as the stage advances, what can we do to diagnose more and more cases in stage 1 and 2? Why are we not diagnosing most of our cases in stage 1 and 2? Can we do something to diagnose more and more cases in this stage? Dr. Sukram, unmute yourself.
Yes, sir.
Yes.
Diagnosing these cases in the early part of the disease usually can be done through the lung cancer screening program. In that, there is a trial in the US which has shown that the LDCT with the high risk group screening has led to the 20 to 30% increase in the survival. And since in the our part of country there is a rise of the lung cancer cases are very high, so we can also start with the LDCT screening program for the diagnosis of early lung cancer patients.
Okay, Dr. Sukram, you've raised a very, very important point, and thank you so much. I wanted this point to come out, that there is an entity called lung cancer screening. Now, what is screening? By definition, screening means doing a test in a normal person. Mind you, when somebody has symptoms and you do some test to diagnose the disease, it's not called screening. By definition, screening is done in a person who has no symptoms but is at high risk of developing a disease. So there is a select group of people who have no symptoms, no visible disease, but are at high risk of developing a disease, and therefore knowing that these people are at a high risk of developing this disease, we do a focused investigation to diagnose that disease at an early stage. This is what is called screening, and this has been applied to lung cancer also in US in people above the age of 55 years with more than 25 to 30 packed years smoking history, and it was found that those people who had annual low dose CT scan screening for 5 years and therefore were diagnosed lung cancer in a very early stage, these people had a 20% better survival than those who developed symptoms and were diagnosed. So there is a role of this in our country. Dr. Mohan, why is it that this lung cancer screening has not yet been applied in a big way in our country till now? What are the problems which prevents us from starting it on a mass level? Dr. Mohan.
It's a very pertinent question, sir. There are two major problems in my mind that they are the main obstacles for the lung screening program application throughout India. Number one, it is the cost of this investigation, and the second is that there is a possibility because of the rampant tuberculosis throughout the country. There is a possibility that many tuberculosis patients will be where tuberculosis lesions will be misdiagnosed as lung cancers, and it will lead to a great burden, financial burden, the psychological burden over the patients. These two are the major problems that Indian scenario that we can face if we apply this lung cancer screening program.
Okay, so Dr. Mohan, you have raised a real practical problem that is there with the lung cancer screening, and I'll just elaborate it further. See, screening, if you do a low dose CT, it will pick up a nodule or it will pick up a patch. Now you don't know whether this patch is infection, fungus, tuberculosis or cancer. Now there are some characteristics described, But none of those characteristics can be taken as 100% and you can start somebody as treatment on that. So you only pick up a patch on the screening. Now you need to confirm whether this patch is cancer or not, for which you need to do further test. Now if you have say 100 patches picked up and you do the further test and then you find that 2 out of those 100 ultimately turn out to be cancer, you have unnecessarily investigated 98 people and subjected them to an investigation just to diagnose 2 people early. So if you have a higher chance of a patch being a lung cancer, your screening will become very cost effective and intense effort effective. But if you have a very low chance, then it will become cost ineffective. And in our country, there are a lot of patches which will come because of tuberculosis and because of other reasons. So this is the reason which is preventing people from doing. But I think despite that, I agree that a time has come where at least the centers like us should start. And I'm happy to take this opportunity to inform all our viewers, and I request all viewers to spread this information across the country, that the Institute of Chest Surgery at Medanta, the Medicity, Gurugram, has started a low dose lung cancer screening program. We have a program in position by which we do screening for the high risk population cases. So low dose CT screening for early diagnosis of lung cancer is available in Medanta, the Medicity, Gurugram. Thank you very much, Dr. Mohan, for that vital piece of information. Dr. Bilal, I'm coming to you, which is for a very important question, which also happens to be an area which is very close to your heart. Dr. Harsh talked about surgery for the treatment and said that for stage 1, stage 2, and stage 3A, the surgery provides the best chance of cure for a patient. So let's talk in more detail about surgery. What are the different methods of surgery? What is open surgery? What is video assisted thoracoscopy or keyhole surgery? And what is robotic surgery? What is your preferred choice and why? Dr. Bilal.
Thank you, sir, for the question. And as Dr. Harsh pointed out, that in early stage 1 and 2 and early stage 3 cancers, surgery offers the best chances of cure. Now, it is important for us to realize that surgery, how do we do the surgery? The aim of the surgery in lung cancer is to remove that part of the lung which consists of the cancer. So in broad specifications, the right and the left lung are divided into different lobes. So the first, on the right side, there are 3 lobes, upper, middle, and lower lobe. And on the left side, there are 2 lobes, upper and middle lobe. So if there is a cancer in the left side, in the upper half, then that upper half of the left lung needs to be removed. Now, the conventional method of doing that is an open thoracotomy or an open surgery in common parlance. So basically what open surgery means is there is a cut that is made on the chest, on the side of the chest. And in that cut, it's about a 15-20 centimeters incision. And then you open up the ribs, you put your hands inside, and you remove the cancer-containing segment or lobe of the lung. And along with that, you remove all the lymph nodes that are there. Now, while this is a good option and it leads to complete removal of the tumor, however, the axis of the trauma of axis, which means that when we want to go inside and touch the lung, and in order to do that, when we make that cut, spread the rib, that kind of trauma to the body causes a lot of inflammatory response and causes a lot of post-operative issues like post-operative pain. There is a higher issue of blood loss. And that is what limits the use of open surgery, particularly in patients who are at a very elderly age group, because they're already very frail group of patients. Now, in order to minimize these problems, the next development came about 2 decades back, which is known as video assisted thoracic surgery or the keyhole surgeries. Now, the key step in the keyhole surgery or the video assisted thoracic surgery is that we make small cuts on the chest. Very small cuts. These are 8 mm to 1 centimeter cuts. And we have specialized instruments. We insert a telescopic camera inside the chest. And without inserting our whole hands with long instruments, we remove that portion of the lung and we remove the lymph nodes. Now, the advantage that it offers is it avoids the large cut on the skin, it avoids the spreading of the rib. It gives us a much better vision because the camera that we use for looking inside is a high definition camera which gives a 10 times magnified view, and therefore the same surgery that required the open cut and rib spreading now can be done with 3 small incisions or 1 small incision, depending upon whether it is a uniportal, a single port, or a 3-port approach. So the same surgery that was being offered in open technique can now be done with 3 simple small 1 centimeters cut, which avoids rib spreading, which avoids cutting on the skin. It leads to lesser blood loss. It leads to a much more clearer lymph node clearance, and therefore this leads to a better outcome in the post-operative patient in terms of the patient has much less pain, the blood loss is much less, the ICU stay is much shorter. The return to work, which is also a very, very important aspect of cancer care surgery, is also much lower in video-assisted thoracic surgery or the keyhole surgery. Now, in evolution of that keyhole surgery, the limitations of the keyhole surgery is that it offers a 2D image to the surgeon, and the surgeon has to use long instruments, which can kind of counterintuitive and is not as ergonomic. In order to improve upon that, now the latest state of art is the use of robotic surgery. Now, the use of robotic surgery involves the use of a very specialized machine, which is known as the surgical robot, which has 3 components, wherein the surgeon sits on a console, and there is a robot which is attached to the patient. And what it offers is, it offers the capabilities of human hand to the tip of the instruments that are going inside the chest. And with 3 small cuts, the same surgery can be done even with more exceptional precision, much more lesser blood loss, higher definition, and leads to almost as good an outcome as an open surgery. This leads to a much shorter hospital stay, and in due course of time, robotic surgery is only going to advance with more features going to be attached to it and making the surgeon's procedure much easier. When the procedure is made easier for the surgeon, obviously the outcomes will be much better. So to summarize, there are 3 modes of surgery for lung cancer. One is the conventional open method, then the video-assisted thoracic surgery or the keyhole method, and the advancement over it is the robotic-assisted thoracic surgical method. As far as our preference is concerned, currently in Institute of Surgery at Medanta, about 85% of cases are being done by minimal invasive method, which includes either a video-assisted thoracic surgery or a robotic-assisted thoracic surgery, because of the definitive advantage that it offers to the patient. So we look at the patient's CT, we look at the patient's condition, and based on what kind of tumor it is, where it is located, wherever possible, we try to perform these surgeries by minimal invasive.
Very, very well answered, Dr. Bilal. Dr. Harsh, Dr. Bilal has described that there are 3 methods of doing lung cancer surgery. A, open surgery, in which you make a big cut, separate the ribs, put your hand inside so you see with your eyes and you operate with your hands. Excellent. 50, 60, 70 years it has stood test of time, except that when you separate the ribs, it causes a lot of breaking of ribs and problem, and therefore more pain, longer recovery, etc., etc. Remove that. You put small holes. You don't see with your eyes. You put a telescope and you see the image on a TV. You don't put your hands inside. You put your instruments and you do the video assisted, that is VAT surgery, or you put robot and you do robotic surgery by same keyhole. So robotic and VATs are the keyhole procedures and open is separate. Now tell me, if robotic and VATs is so good, why are we not doing 100% of the cases by this? Why should the open surgery not be banned at all?
So very important question. Very important question. Obviously, as Dr. Bilal has stated, that robotic assisted thoracic surgery or video assisted thoracic surgery are the future of thoracic surgery. We are able to perform these surgeries as good as we would have performed the same surgery by open method in around 85% of the patients. But in rest of the 15% of the patients in a country like India, which is endemic for tuberculosis, where almost 60 to 70% of the population has TB at one time, diagnosed or undiagnosed, there are problems of there are many problems with video assisted thoracic surgery in those patients or robotic. The problems start with SS into the chest cavity. There are a lot of adhesions. The adhesions are so dense that we cannot assess the cavity. We cannot assess the size of the tumor inside. The whole view is barred. So in those cases, we go for open surgery. The other problem with the Indian population is dense adherence of the arteries, which are which we have to divide when doing these surgeries. Because of some point of time they may have got tuberculosis or some infectious problem, which are very common in the country. So in those patients, to avoid injury to those vessels, which can be life threatening at some point of time, the open surgery has got some role. But obviously, as the expertise has grown, as the instrumentation has grown, the vision has grown. Now, firstly, we used to do 50 or 30 to 50% of the cases by VATS. Now, in the last few years, the number has gone to 85%. So in institute, as the expertise will grow, as the surgeons will become more confident, as the instrumentation will increase, as the socioeconomic status of the people will become better, as we have seen in China, that now the rate of tuberculosis is much lower than they were having 20 years back. So we are passing through the phase that China was passing 20 years back, when tuberculosis was endemic in that country. The adhesions were too much, the adherence of the lymph nodes was too much, and still
Okay,
open
Harsh,
surgery has got.
I'll stop you. You have stated that there are situations where open surgery is preferable, and there are situations where but the message that we want to, as a group, we want to convey that while keyhole surgery, that is VATS and robotic, offers less pain, faster recovery, same cancer operation, etc., there will be situations because of various technical and other reasons where it may not be safe or prudent to continue with keyhole surgery, and there we always fall back on the open surgery, and therefore open surgery will continue to have a place. If any was to say that open surgery is banned or bad, it's a wrong statement. Open surgery is there to stay. Dr. Sukram, many times patients come and ask all of us in the OPD, Doctor Sahab, I want the surgery done only by keyhole. Suppose you are faced with a situation, you are doing keyhole, but you are not able to do as good an operation by keyhole as you would have loved to do in open surgery. Now, at that stage, since you have made a commitment to the patient to do keyhole, would you persist with keyhole or would you open? What is the message we want to give to public? Quick, please. Dr. Mohan,
Yes, sir.
unmute yourself.
Yes, sir. Sir, I will not persist with the keyhole surgery. Even if I have committed 100%, we will be able to do it. The point number one, which we look at, the first thing is that in any patient we have taken up for surgery, the first thing we look at is safety of the procedure. Procedure should be safe to the patient. And second thing which we do is completeness of the job. It should be done with the if we are not able to do with the VATS, then we should convert back to the open surgery, because the two are the things. Because third thing is the cosmetic things, whether we are doing with the method robotic or keyhole or VATS or whatever it is. So the point number one is procedure should be safe. If it is not safe, then we should convert to the open. And second thing is completeness of the job, because the patient cannot be planned for the second job or second surgery. So it is better to do in the one go.
Very well stated, and I would like to reiterate this point that when we take up our patients for surgery, all five of us as a group, never commit to doing anything by VATS or RATS or the robotic. In order of priority, I would restate what Dr. Sukram very elegantly said, that complete cancer operation is the first priority. Doing it safely is an equal priority. Whether you do it by open or VATS or robotic is the next priority. You never do VATS at the cost of completeness of the cancer operation. As a group, all 5 of us, we want to give a categorical and clear message. Doing complete, good, safe cancer operation is our first commitment, first priority. If we can do that by VATS or robot, which we are able to do as a group in about 85% of our overall lung cancer cases, we love to do that. We are happy to do that. But we never ever compromise on the completeness of the cancer operation or safety of the operation in order to complete by VATS or robotic, in which case we convert to open. Wonderful, very wonderful discussion, all 4 of you we've had. Now we have about 5 odd minutes, and I'll shift gears and I'll move to pollution as a cause of increase in lung diseases, because I believe that it is the duty of every treating doctor to also talk about preventive steps. Dr. Mohan, you've been very active, all 4-5 of us with Lung Care Foundation talking about pollution. Would you like to give some message between, relationship between pollution, lung cancer, how pollution is damaging our health, and what as a group we are doing to increase awareness about this in the society? Quickly, so that I can have a round with all 4 of us. Mohan, unmute.
So pollution is a very significant risk factor in these in the present days for the incidence of the lung cancer. As it was stated earlier, the more and more young generation, more and more non-smoker females in non-smoking families are developing lung cancer. The link that can be related to why this is happening in those patients is the increasing air pollution throughout the major cities throughout the India. So it can be either indoor pollution or it can be an outdoor pollution. I'm not going into why this pollution is increasing, and I will be discussing how we can. So we have started a foundation called Lung Care Foundation, where we are raising the awareness about this lung pollution, how to tackle this pollution, how to tackle this pollution effects, and we are educating the people, educating the students, so that the awareness will go throughout the people to the 1.3 billion populations of India.
Dr. Bilal, would you like to throw some light on this campaign, #ICareForLungs? Just explain to our viewers what it is and what it is all about. Dr. Bilal.
Sir, this is a part of our Lung Care Foundation campaign, wherein we started this campaign, I Care for Lungs, because of the ubiquitous presence of pollution and the epidemic proportions in which the lung diseases have increased. The I Care for Lung program was initiated in order to raise awareness about the diseases that that are affecting the lungs, and we initiated this program in order to create a massive awareness across the India amongst people about the various lung diseases, including lung cancer. And why is it very important is because, unfortunately, in our country, unlike in Western countries where people are very cautious about their health, and even a minor deterioration in the health would be immediately reported to the doctors, we started this program so as to raise a similar kind of awareness in our country, and also to the fact that make people aware about the problems that are related to pollution. So unless people are aware about these two major issues, that is the lung health as well as the pollution, the action will not be taken in order to mitigate the side effects of this. And therefore, the I Care for Lungs program was started.
Yeah, very well stated, Dr. Bilal. It's an irony that lungs help us to stay alive because they inhale air 25,000 times every day, inhaling about 10,000 liters of air into them in the process to keep us alive. But in the process of inhaling that 10,000 liters of air 25,000 times a day to keep us alive, the poor lungs become the dumping ground for all the toxins and chemicals which are present in the air that we breathe, and lungs become the kind of filtering agents where all that dirt and dust, the dhool and dhua, gets deposited, killing the health of the lungs in the process. So lungs are breathing to keep us alive, but they are dying in the process of keeping us alive. And therefore, we as doctors, as chest surgeons, all five of us see this effect every day in the OT, where we see black deposits on the surface of the lungs. And that is why all five of us, while continuing to treat lung cancer and other diseases, we have taken it upon ourselves the task of sharing this knowledge from our operating rooms to 1,300 million people across the country, that friends, because of breathing dirty air, our lungs are dying, and if we don't do something active to protect the health of our lungs, ultimately our health will get ruined. And that's why this concept hashtag I care for lungs, where we are trying to raise the awareness about the pollutants in the air which cause damage to the lungs. And because we believe that there is a AAA approach, only when people become aware, they will become awakened to the loss, to the damage which is occurring to the lungs, and then only they will take actions to prevent this from happening. So this is an effort by Lung Care Foundation to raise awareness and tell people to care for this lungs. Dr. Bilal, Dr. Harsh, Dr. Sukram, Dr. Mohan, it's been a real pleasure discussing lung cancer, its causes, its treatment, its prevention, and also about air pollution, etc. In the last 1 hour. I think all of you have provided very practical, very useful information. There are some questions which we'll take and try to reply. But in the meantime, I take this opportunity to thank all four of you for providing this information. And I promise to people that we as a group at Institute of Chest Surgery at Medanta, the Medicity, Gurugram, will keep coming back to you, ladies and gentlemen, with information which will be useful for the diseases which afflict each one of you individually and as groups. And we would request all of you to please disseminate this information to your friends and other people, because information is the first step towards rectification of any problem. Thank you very much. What are the questions? So Mr. Nikhil has asked a question. I have been experiencing issue of breathlessness and heavy energy loss. Chest X-ray is clear. I think what we'll do, we'll address these individually to these people, because we would not like everyone's time to be wasted. So once again, ladies and gentlemen, thank you very much. It's been a pleasure for myself and my colleagues, Dr. Bilal, Dr. Harsh, Dr. Sukram, and Dr. Mohan, to be associating, interacting with all of you. Have a wonderful day. Have a safe, lung damage free time ahead, and best wishes to all of you. Namaskar.
Now.
Namaskar.